Well, welcome again to all of our listeners and viewers to another in our series of interviews with the experts from Mayo Clinic. I'm Malcolm Bell, your studio host today, and it gives me great pleasure to introduce our guest today, Dr. Gosia Wamil, who's an Oxford-trained clinical scientist. She's an expert in non-invasive cardiovascular imaging, heart failure, cardiomyopathies. She is currently a senior research fellow at Oxford University and is a consultant cardiologist in Mayo Clinic Healthcare in London. So, Gosia, it's an absolute delight to have you here this morning. Well, I guess it's the afternoon there in the UK. But welcome.
Thank you so much for inviting me. Thank you. It's a pleasure.
Well, we have a big topic to cover in a relatively small, brief period of time, and it's about the use of cardiac MRI in heart failure and cardiomyopathies. And I'm just going to start with a very broad question, and that is, when you're using cardiac MRI, does it change your management decision pathway?
Thank you for that very important question. So over the last several years, the role of cardiac MRI evolved. We used to think about cardiac MRI as a nice to have imaging modality. We now consider MRI as a decision-making engine in heart failure, but also, and probably most importantly, in the cardiomyopathy field. So the role has evolved, and it has been highlighted by clinical guidelines, both in Europe and also in the US. So cardiac MRI is now I've considered as a not only very useful but very important imaging modality in managing of patients with cardiomyopathy and heart failure. So there are probably 5 instances when I would strongly insist on having cardiac MRI when I manage patients with heart failure and cardiomyopathies. And those would be as follows. So firstly, and most importantly, when I'm questioning whether we are dealing with ischemic or non-ischemic cardiomyopathy, and this has significant implications for our decisions about taking a patient to the cath lab, revascularization, decision about ICD implantation, viability assessment, and so on. Secondly, in cases with heart failure preserved ejection fraction, and that's probably something new, we are offering patients cardiac MRI also to uncover those rarer types of cardiomyopathies, such as, for example, cardiac amyloidosis, that might be missed if we just use that label of heart failure preserved ejection fraction. So we use it for precision diagnosis. Thirdly, I would definitely consider and promote a use of cardiac MRI in patients with who present with myocarditis or inflammatory type of cardiomyopathy, such as cardiac sarcoidosis, or other types of inflammatory cardiomyopathies. And this is because MRI can play a significant role in our decisions about using immunosuppression. Fourthly, I would consider MRI in all my hypertrophic cardiomyopathy patients, and especially when the history doesn't really guide me whether there is a potentially another differential diagnosis, such as hypertensive heart disease. And this, again, translates into cost savings. We may avoid family screening and lifelong screening of our patients. And lastly, it should be considered in patients who present with abnormal rhythms, especially those that present with hemodynamically unstable VT, where we are questioning whether there is a scar. We want to assess the pattern, the burden of the scar, and this can guide us in our decisions about ablation and ICD.
Well, that covers an incredibly broad spectrum of cardiovascular diseases, particularly in our heart failure and cardiomyopathy patients. And certainly when I look at the literature and look at what you're doing and the things that you talk about, you're talking about phenotypes and biomarkers. And I think at least to me, I think the term biomarker when we're looking at cardiac MRI is perhaps relatively new. And I think it's true. We turn to MRI increasingly now, but very often, to distinguish myocarditis from myocardial infarction, to look at how we function, great images to see. But maybe we could maybe let's just focus on the ischemic patients at the moment, and maybe you could describe exactly what you're looking for. And maybe this is beyond the late gadolinium enhancement, the sort of the tissue characterization. And maybe we can just start even just with the acute MI that we're seeing in the patients. Patients just had a STEMI. And tell us what you'd be looking for there and how that might help guide treatment or assessment of prognosis in the acute MI situation.
So again, a very, very important point that you raised. Historically, late gadolinium enhancement and scar assessment has been the strongest advantage of using cardiac MRI comparing to echo that is much more widely available. And the reason for that was that we are able really to show in our patients who present with heart attacks whether there is damage to the myocardium and how rescuable the myocardium is. So with one single scan, we are able to inject a late gadolinium enhancement and look at the late gadolinium scar assessment. We can describe the viability of the myocardium in all segments, and with the novel techniques such as tissue characterization, T1, T2 mapping, ECV. So we are able also to look a little bit more into details into the edema, the inflammation.
Maybe just for the sake for some of our audience here, you said ECV. That's extracellular volume mapping. Could you just describe that? Because I think that's a term that we're probably not, as general cardiologists, used to hearing. Really, it has something to do with the extracellular matrix, but
yeah. So with the late gadolinium enhancement, probably the most well recognized and known technique in cardiac MRI, we are looking at the localized fibrosis, such as scar after infarction. The novel type of techniques are the mapping techniques, allow us to look at the diffuse fibrosis in the myocardium. So this is the strength of the cardiac MRI that not really any other cardiac modality can deliver. It is particularly important in cardiomyopathy field. So we've for many years we've talked about that hypertension, diabetes, so common comorbidities can cause diffuse fibrosis of the myocardium, very different from the localized scarring that we see in heart attacks. And this is what the ECV, the mapping techniques can detect. So we can map with those techniques, if we perform sequential scans, also the progression of the disease. And with some cardiomyopathies, like, for example, cardiac amyloidosis and the novel treatments, the disease-modifying treatments, those novel techniques, mapping techniques, and those novel markers, biomarkers, can allow us to detect what is happening in terms of assess the prognosis of the patients and whether the disease is getting the remission. So those novel techniques, so we very often compare those techniques to a non-invasive myocardial biopsy, because that is the level of the detail that we can get to. So we assess inflammation, we assess fibrosis, and in the entire myocardium.
Get back to that acute MI patient. So let's just take a patient who's had a STEMI, they've come back from the cath lab, the vessel's open. Tell us what you'd be looking for and what the utility is of early imaging with cardiac MRI. We're used to seeing things like microvascular obstruction, but what else would we be looking for? And can you predict from these biomarkers or your mapping studies which patients are going to adversely remodel?
So yes, we can scan. So we can scan a patient in the following an acute cardiac event. There are two parts of the scans that are very important, or maybe three. So seeing images, like in an echo, we assess the function, and we can compare what this with the follow-up images and see how the function changed. We can assess the regional motion abnormalities. But with the tissue characterization, we can also assess for edema, for swelling of the myocardium, and compare it with the area of infarction, of scarring, so with the late gadolinium enhancement. So we are able to assess for hemorrhage. We can see microvascular dysfunction, so those very early changes. And then with a follow-up scan, we can see how much the myocardium has recovered. We can distinguish with our techniques the core of the infarct from the areas that would be that could heal and recover if we offer a patient the 6 weeks or 4 weeks post-MI scan. So all this is available to our patients. Post-MI patients, though, especially those STEMI patients, frequently will also present with complications, depending how quickly they get into the cath lab. So there is a number of other complications of myocardial infarction, such as VSD, rupture of the myocardium, the acute the dysfunction of the mitral valve that we can also assess with MRI, although echo still plays a very, very important role in that field.
Did you learn anything in those acute cases or in follow-up looking at the non-involved myocardium? Are there any changes there that you're maybe picking up, the things that we don't even generally look at? We think they're normal, but do you have anything to say about that?
So we always compare the infarcted segments, so territory that where we know from the coronary angiography that was affected to the what we call remote myocardium, so the part of the myocardium that we would regard as normal. With cardiac MRI, we see how widespread is the swelling of the myocardium, which is then really the first initial reaction of the myocardium and tissue to in absence of the blood flow. So we can see and compare which part of the myocardium is likely to recover. And this is something that echo can not fully assess after the acute event.
Just as we begin to close this discussion, I'm very interested to hear then, we talked about the ischemic situation in the acute ischemia. And obviously, pathways in the past, it's usually an echo first, and then we may be talking about doing a biopsy. Again, now we're talking about sort of the non-ischemic cardiomyopathies. We may be doing nuclear scans looking for perfusion. We may be doing CT scans or invasive angiography. Do you see cardiac MRIs in a role that maybe it would obviate the need for most, if not all of those?
Mm-hmm. So that is a very, very important point. And so we do believe that cardiac MRI is a versatile technique. It's a non-invasive. It allows us to combine assessment of anatomy, assessment of the function. We can offer stress perfusion imaging, so to the similar level as nuclear scans. With novel techniques such as 4D flow, we can assess hemodynamics. We are very good in assessing valves, especially regurgitating valve. We can assess the shunts. And with the tissue mapping and so tissue characterization, we can replace many of those in the past were the cases where we had to use a biopsy, and we believe we are better in assessing rare cardiomyopathies than the tissue biopsy because we see the full myocardium, and this has always been a disadvantage of a blind myocardial biopsies.
So maybe my closing question here is, in the patients that you're seeing now with, let's say, new onset heart failure, including cardiomyopathy, whether it's with preserved or reduced ejection fraction, where does cardiac MRI come in terms of the cascade of testing? Does it replace the echo? I mean, typically the echo is the first thing we do. I'm just very curious what you do in your practice and where you see that practice going in the future.
So I'm a multimodality imager, and therefore I value highly all cardiac modalities. And unquestionable, echo is going to remain the first line. It is a cheap test. It's widely available. All cardiologists are trained in obtaining images and assessing patients with echo, so it's going to stay. The cardiac MRI evolved to the level that is evidence-based, is supported by clinical guidelines, and has a very important role in what we call deep phenotyping. So it's important to use and think early about using MRI when we are questioning a possibility of an underlying diagnosis such as cardiomyopathy, or a diagnosis where a specific assessment of etiology may have an important influence on what we do next. So echo can tell us about dysfunction, can assess ejection fraction. MRI can tell us what is actually the diagnosis, what caused this, and also help us in many cases what to do next. So it evolved to the point that with those novel imaging biomarkers, we can make a judgment whether specific disease-modifying therapy is required. And in some cases, we can also monitor the response to the treatment. So I do believe that MRI plays an important role in managing patients with heart failure and cardiomyopathies. It should be embedded in the pathways for patients with heart failure. And we, as MRI doctors, should be working very closely with colleagues within the heart failure teams and cardiomyopathy clinics. And we should be delivering the type of the scan that answers clinical question. So there is an important role for us also to recognize those needs and offer reports that are actionable from the clinical side. So the role of cardiac MRI is recognized by all cardiologists. So I think that is the future.
Okay. Well, thank you very much. That was a very balanced perspective of a complex problem and then where the role of cardiac MRI should be, and it's clearly evolving, and that we've seen this and using it much more than we have in the past. So really, we're so lucky to have had you talking with us this morning, and I'm sure that our listeners and viewers have learned a lot. So really appreciate the time you spent with us. So thank you so much.
Thank you so much for inviting me. Thank you.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Mark Moline, Wound Clinic Director of the Vascular Center at Mayo Clinic in Rochester, Minnesota. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Head to cveducationmayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses, all created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.